Good morning, everyone. Thanks for joining us today. My name is Madeline, and I will be your moderator for this session. This session is IC 84, the ATP as the case manager. If you have any questions, please feel free to put them in the chat, and our presenters will go ahead and answer those at the end of their presentation. All right, I'll go ahead and pass it off.
Hi, thank you. Good morning, everyone, and thank you for joining us this morning. I'm Mike Seidel. I'm an ATP CRTS. I have over 35 years experience in the CRT industry. I'm currently the Vice President of National Accounts for New Motion, a past chair of the RESNA PSV, past president of NARTS, and I currently serve as one of the review chairs for NARTS. I'm also the current president of the Kansas City chapter of CMSA. And I'll let my co-presenter Sue introduce herself.
Hi, everyone. I'm Sue Redepenning, and I'm an occupational therapist and an ATP. And I own a company called Live Life Therapy Solutions. And in my company, we have OT, PT, speech, and assistive technology and engineers. And we work in a unique model in that we have state grants and use waiver funding. So a lot of what I'll be talking about today is sort of on our pilot project and on how to make all of this happen with durable medical equipment and communication.
So at the end of this session, we would like you to be able to define case management, define 3 different types of case managers and their roles, and able to identify 3 different responsibilities of the ATP when working with case managers. So what is case management? It's defined as a collaborative process that assesses, plans, implements, coordinates, monitors, and evaluates the options and services required to meet the client's health and human service needs. It is characterized by advocacy, communication, and resource management, and promotes quality and cost-effective interventions and outcomes. We can apply this definition as well on how we as ATPs work with the individuals we serve to meet their ATP needs. As we review the various types of case managers, I ask you to keep this definition in mind on what they, along with those individuals we serve, expect from us as ATPs, and how we can work to deliver good outcomes.
Yep, and on this one, what I would say is there's a lot of moving parts and moving pieces. So that team coordinating and communicating is vitally important, or the person that we're helping gets really confused, doesn't really understand who they should be going to, who can answer their questions, and then starts to not trust what's going on. So that communication, those teams working close together and knowing whose each role is with the person is super important. And it really helps build trust, and it helps build the quality of what we all do.
So what does a case manager do? I think I skipped one, didn't I? Maybe. Oh, who are case managers? I'm sorry, I'm on the right one. Who are case managers? Nurse, medical case managers, workers' comp case managers versus private insurance case managers, state funding waiver case managers, independent living case managers. I think it's interesting to know that medical case managers have a professional certification, much like the ATPs. The CCM certification, or Certified Case Manager, is provided through the Commission for Case Management Certification. And more can be found about that on www.ccmccertification.org. There are established eligibility guidelines, a standard of practice, again, much like RESNA ATPs. With the CCM, you do have to be a licensed clinical medical professional, such as a nurse, therapist, or social worker. A nurse medical case manager is just that, a nurse or other licensed medical professional. They can include social workers, PTs, OTs, etc. They can be employed in a facility or a health insurance company or self-employed. Work comp versus insurance case managers are different only by their employer and the extent of the individual's coverage limitations. Work comp can either have no limitations to covered benefits, while private insurance will have coverage limitations. Both case managers are instrumental in the approval and authorization process of AT. Sue?
Yep. So state funding and waiver case management, I don't know how much any of you guys work with the waiver side in your state. With our grants that we have, I have over 30 years of experience too, and the last 10 years has been on the state funding side. I never knew that side of our work as professionals until I had this grant. And in Minnesota, when people can't get things covered by Medicaid or Medicare or insurance, and they have a waiver, so they're of low income, have medical assistance, they have a waiver case manager. And that waiver case manager is in charge of knowing, and this isn't impossible to know all of this without the team, but they're in charge of knowing not only what Medicare and Medicaid would pay for, but when the waiver would kick in. And so what I see is that these case managers are definitely a part of the team. They're frontline in that they're working with a group of people that have Medicaid funding or Medicare funding, have waivers, and they're trying to understand what goes to what payment sources and who to use for that. And so they end up being a player, and they need our team to be able to understand where to go to talk to an ATP, or to even know where to start when it's durable medical equipment. And then also when things aren't fully funded by Medicare and Medicaid, they can get the waiver in some states to kick in for the additional funding. So they're social workers by background or nurse case managers by background. They do have that type of training and background. And then independent living case managers. So a lot of people that we see have independent living services who, again, are frontline, see what's going on in the home, see what's going on for the person, might be one of the first people to understand that something's needed for durable medical equipment, but don't always know who to reach out to. But they're definitely a part of our team and definitely an important piece in the puzzle that we'll talk about. And then the therapists, like Mike said, are important too. OT, PT, speech, anyone that's in there seeing what's going on for the person and what they need.
So what does a case manager do? And if we look at this, a nurse case manager can work in an inpatient capacity or outside a facility. And depending on which one can determine what their role is. Inpatient case managers will be managing to ensure the stay in the facility is approved and coordinating what is needed to meet a discharge date. Work comp case managers will direct who to call to provide AT need or manage the request directly and provide approval. In addition to AT needs, they will also be managing inpatient stays, procedures, home health, therapy, home mods, vehicle, med supplies, etc., as required by the individual. Their scope of service may be expanded as a work comp case manager over that of a private insurance case manager. Insurance case manager will provide a list of approved providers for AT needs and may assist to facilitate approval or direct you to what process to follow for approval. I've mostly a work comp case manager may become more involved in that client's case to again facilitate all the needs of that care. They may be rebuilding homes, putting in elevators, purchasing vehicles, all with the goal of getting that client back functional and hopefully employable again at some point in life. An insurance case manager is going to be limited by coverage determinations of the plan that individual has. Sue?
Yep. So then the waiver case managers, they do have a little bit more freedom in some states because if Medicare or Medicaid don't pay for certain things that a person needs, or if a person needs additional equipment, maybe MA is paid for a wheelchair and they need a transport chair or some additional things, they're going to be thinking about what could be covered by Medicare, Medicaid, and then also additionally, what else the person might need that the waiver could cover if they're able to do that. What I see is oftentimes the case managers, they're trying to get the person what they need, which is what they're supposed to do, but they don't understand the whole funding and like who to go to and who does durable medical equipment, what pieces are needed to get that funded. So sometimes what I see in our state is that the waiver pays for additional things that could have been paid for by insurance or Medicare or Medicaid, because the waiver case manager is trying really hard to get the person what they need. But obviously the waiver doesn't have unlimited dollars either. So what we're trying to do is help educate them as part of the team on that you do want to try Medicare, Medicaid, where it can pay for things and insurance, and then save the waiver for those things that can't be paid for that way. And so that's what they're constantly doing, is being that big picture of the funding and what they're supposed to do for the person that they're coordinating things for. And those case managers do go into the home, or right now, most of them are remote, but they do go into the home at times, still even during COVID, to see how things are going. And so that person is a great frontline person to our whole team, because they actually get to see the person in their life. And it could be assisted living, group home. It could be that they live in a home of their own. I see a question about local waiver programs. So each state does have their own waiver programs, and it would be on your state's website. So our state is Minnesota DHS, and under that department, they have all of their waivers that they provide. And I can put a link to what ours looks like when Mike is talking, and then you would replicate that for each of the states you're in. Every state does have their waivers set up differently. So every state gets federal money and they get state money, and they decide how to split out their state money. And in our state, for Minnesota, for example, what our state has decided to do is that for every federal dollar that we get a state dollar. And they've created different types of waivers depending on the age of the person and the disability of the person. And then that person has money to access for assistive technology, for durable medical equipment that's not paid for in other ways that the case manager can utilize. So we want them to be a part of the team and understand that piece. To qualify for a waiver, the person needs to qualify for medical assistance. So it is somebody of lower income. There are people who are able to pay in to get medical assistance, or be of low income to qualify, and then have a significant disability that impacts their life would qualify them to be assessed for a waiver. So it's not a nonprofit, it's part of a state funding program, but it is for people who are of lower income, people who have a significant disability. And then for the independent ILS workers or independent living coordinators, they also do frontline work and are in helping people in their homes. They also need to understand, like, when you want to start looking at durable medical equipment for someone, what are the steps? Their role is more to reach back out to that social worker, that case manager, that medical model, help the person be able to reach back out to the right places to start looking at this. Because oftentimes the person does not know or have the ability to get there without someone helping to coordinate that. So a lot of independent living case managers help with those pieces, help coordinate the ride, help coordinate getting the person to the right resource. So it's really important that they understand what those resources are.
Yeah, I've seen a lot of independent living case managers, in the states that I operate in, or have as an ATP. Individuals have the ability to live independently in their own home instead of going to a facility, and they hire their own staff. The independent living case manager then helps facilitate them hiring their staff, and then the agency the independent living case manager works for coordinates they manage the salary of those caregivers the individual hires. Is that what you've seen in Minnesota? So yeah, it's a very good benefit for folks. All right. So there we go. What do am I on the right slide here? Do I need to advance one more? Let me see here. One more. What do case managers expect from ATP suppliers? And again, Sue and I kind of are splitting this. I'm focusing and addressing this from an ATP supplier standpoint, while Sue is addressing it from a clinician standpoint, where we're both ATPs and work with these individuals, but we're kind of splitting our focus and talking about some various benefits. So the role of the ATP supplier for seating and mobility, the seating and mobility professional, collaborate with the medical team to incorporate the client's goals into the treatment plan, do the client assessment, trial of equipment, match client goals to appropriate equipment, obtain the necessary documentation, verify coverage and submit the prior authorization, deliver, fit, train, and follow up, and accommodate any unexpected changes in the client's condition. I feel this is what case managers do expect for us as case managers for the individuals they are working with. And if you look at, RESNA has 22 standards of practice for ATPs, and a few of those stick out to me as key when working with case managers. And the RESNA standards of practice can be found on the RESNA website at www.resna.org. But standard, number 7, individuals shall cooperate with members of other professions where appropriate in delivering services to consumers, and actively participate in the team process. Interprofessional collaboration is the hallmark of providing AT services that has been linked to better outcomes. Standards of practice number 8, individuals shall offer an appropriate range of AT services, which include assessment, evaluation, trial, simulation, recommendations, delivery, fitting, training, adjustments, and/or modifications. While it is not required for the ATP to perform all of these services in a client-centered model for service delivery, it is best practice regardless of the AT recommendation. When a case manager refers to you, their expectation is for you to give them a full and honest evaluation of the client's needs. Is the AT ordered by the physician or therapist going to meet the client's needs as expected? Will it work in the home environment? Can it be transported, or what is needed to transport it? Collaborating with the team to ensure recommended equipment is the best to achieve desired outcomes. Standards of practice number 9, verify consumer needs by using direct assessment or evaluation procedures with the consumer. While emerging technologies and innovation have and will continue to impact the definition of direct assessment, it is highly unlikely that a questionnaire or phone interview with the consumer will ever provide sufficient information necessary to make an accurate recommendation for assistive technology. But it may be a place to start. This can give you an idea as to how complex the client is, how complex the intervention may need to be, how much time to allocate for the encounter, and what methods will be most effective. Direct assessment allows you to consider the physical, functional, and environmental needs of the consumer and may be accomplished with everyone physically present by teleconference with video and audio capabilities, or a combination of the two. In January of 2021, the Clinicians Task Force put together a terrific guide for using telehealth when servicing clients needing complex rehab technology. And that can be found on the Clinicians Task Force website at www.cliniciantaskforce.us. Many long-term relationships with case managers are based on honesty, trust, and accountability.
So for me, what I see in this role for the whole team is unique because I have worked in a clinic and I've worked, I'm an OT, but I've worked in wheelchair seating and mobility with PTs and OTs. And I now work for the state as a state contractor with my PTs and OTs. And we go into the person's home. And so we interface now with this whole team that we're talking about today. So when I'm talking about the team and the interactions and the complexities of it, we're kind of in the thick of it in a very unique role. And so in my program with the state of Minnesota, we're also collecting data on doing things this different way. What does that impact on the person and the team? And so I'm going to share that a little bit because I think that's unique. And I've never, besides these 10 years, ever been able to practice this way. So in my practice, because we're a state grant, we're not billing insurance or medical assistance or Medicare for our services. Our services are covered by our state grant. And that is because we are working in assistive technology, durable medical equipment, and home modifications. And it's the only work we do. So we're really focused on that and really understand that piece. And so we are wanting to help all OTs and PTs in Minnesota that we can, and the people we see, to understand assistive technology, durable medical equipment, and home modification. So we can get in there and help occupational therapists and physical therapists in our area that are seeing people in the clinic to either understand the technology a little bit better, or to be able to, they'll do the assessments in the clinic and start with the ATP for the vendor. And then we'll get involved and go into the home to see how that wheelchair is working in the home and all of the things that the person's doing and needing for it in the home, because maybe that physical therapist can't do that or can't remote in. So we become part of a team in that way. And we're also doing education to that case manager that's unique, like the waiver case manager, the independent living skills case manager. We have the time to do that in this grant. And so we're showing the state with that time how important that becomes to the person. So that missing link that we all don't get to have when we're working in a clinic or even in home care, because we have deliverables and we're billing and we have to follow those parameters. We're starting to be able to see what a difference adding these extra unbillable time in there that the grant pays for can do in this communication interaction. And so for our team, because we're getting in there and working with all the players, what we're really seeing is that this team is quite large, and a lot of people are trying really hard to match the person to the technology they need, to the durable medical equipment providers, but they don't really know what they don't know. And so they don't know where to go. And so what we're trying to do in our state is show the Department of Human Services what pieces are lacking so that that training can occur for the waiver case managers, the state case managers, and the independent living skills specialists, so that we all do get the person into the right place. And then also there's very many people that we see that can't get to a clinic, they can't get into a specialist. And so we're also helping to share that with the state, with our role in going into the home to provide these assessments. So my team can, as OTs and PTs, go in and look at everything from shower chairs to high level power chairs in the home and match with the ATP. Because of that, we are seeing too that important role with understanding all the pieces that go into play in getting durable medical equipment in a wheelchair and setting those realistic expectations with the person. Oftentimes people that we see don't understand how long this can take, especially if we're doing all the pieces the right way, how long the assessment piece takes, that we need to do some trials, that we're going to be working together as the OT or PT and the ATP to bring those out to fit the person. And then when the product comes, that oftentimes if we can, we want to be there as the OT or PT when the ATP from the vendor brings the chair out or the durable medical equipment out, because I want to make sure the person does really fit in it still. They understand how it works. It's all set up for them. We finish the fitting together and I do any additional training that I need. And so what we're seeing is that there's a lot of pieces that we're missing in communicating with each other and then also communicating realistic expectations with the person. And so we're in our state trying to make a list of all that and then work with ATP vendors like Mike and I have been talking about, so that we're all working collaboratively together. Because there's things I have to do as a therapist to help get the doctor's order and to help get the face-to-face for equipment that needs that. There's things I have to write up. There's things that the ATP at the vendor has to write up. And we need to make all those pieces smooth and make sure the person understands it.
Thanks. So it kind of, again, boils down to communication and collaboration with the team. A client-centered approach with your client in the middle, surrounded by all the players, and this may not be all of them, but it's a large chunk of them. A client-centered approach ensures that we achieve the desired goals and outcomes. And we'll continue talking more about how an ATP can drive all this and be the leader in this transaction to work as a case manager within their own team to help that client's case manager meet the goals for the individual. Another standard of practice that I think is important to hit up on here is individuals shall inform the consumer about all device options and funding mechanisms, regardless of finances. And I think this is an area that we as ATPs on the supplier field have not done a really good job of. No matter what funding the client has, we need to do an assistive technology evaluation and make recommendations of what will meet their needs and provide them all options and let them decide whether they can find the financial ability to get it covered if it's not covered by their insurance. The ATP has an obligation to the consumer to use their skilled professional judgment when making equipment recommendations to meet the identified need of the consumer and not be unduly influenced by what may or may not be covered benefit or paid for by their third-party payer. Certainly, this is easier said than done, but an ATP must explain why they are or are not making any recommendations, as well as the pros and cons related to the recommendations, so that the consumer can make an informed decision as to how they want to spend their financial resources. Another standard of practice for an ATP is consider all future and emerging needs. A crystal ball would make this a whole lot easier. Absent that, when contemplating an assistive technology recommendation, the ATP takes into account the client's current need. It is also fundamental for you to understand the consumer's diagnosis, prognosis, and any contributing comorbid conditions or factors that may affect their future AT needs as well. Aging with a disability is just as important to consider as the consumer's risk for secondary medical complications or anticipated changes with a progressive condition. When, where, and how the assistive technology will be used should also be reviewed, as the recommendation may be appropriate for use in one environmental setting, but not work well in another. Further, it's important that we keep up with emerging technology and innovation, as this plays an important role in serving our clients, being mindful that we also have a wide array of individuals that range from a technophile to technophobes when it comes to their level of comfort with AT. And remember, overprescription may be just as inappropriate as underprescription. And funding can make this very difficult at times. This presentation, I don't want to go into the discrepancies in funding. Sue kind of hit up on a little bit of with there being a waiver program and dealing with more of a Medicaid population. And I'm approaching it from all aspects, from workers' compensation to private insurance to Medicare to Medicaid. It's certainly easier on if you have a work comp case and you're working with a work comp case manager to look at future needs and other benefits that may benefit the client, where with Medicare, Medicaid, private insurance, those options just aren't available to you. Sue, do you have any comments about this?
Yeah, so I think the big thing that I see is that at times we can lose the person-centeredness in our work, which we don't mean to as a team. But with our grant and going into the home, a lot of the people that we see, I have seen have a lot of durable medical equipment in their home that's not being used or that they stopped using. And when we really look at why, a lot of times the person doesn't feel like they were part of the team, that they were prescribed something, dropped off something when they weren't really dropped off something. When I look back, they did have an assessment, they did have a team, but for some reason didn't feel part of that team. So I think that person-centered role that we all play as a team is really important, that the person that we're seeing is integral to that and their caregiving team, and that we in many ways need to have the person hear, touch, feel, see, and use the equipment if we can in a trial, so they really have ownership too. I think that part in our process, because in a clinic we get really busy in our assessments together, we get really busy, doesn't always happen, or the person doesn't perceive that it has happened. So I like this graph in that the person, and oftentimes we call, like in my work, I call the person, I see a person, but that's because we're person-centered work, we're social model, even though we're medical. But client, patient, whatever word we use for the person we're helping, that person is integral and central. And then we listen to the caregivers and things too, but always back to that person. And then each of these people, the case manager, the therapist, the doctor, the AT supplier, the caregiver, then becomes central to that person feeling, understanding, and knowing the process. Another thing that I see too is oftentimes the person just gets overwhelmed with everything that's going on, and they don't understand how long this is going to take and who all the players are and who's doing what. And so giving resources for that, explaining it, but also giving that in paper copy, making sure that everyone that's on this team understands who's doing what, so that all those pieces can keep going and the person knows who to contact at each phase. So I know, like in our group, we're starting to put together sheets that we give to the person and their family. And then also, we're also trying to create a framework for who does what at what phase, so that I can teach the case manager that's in the waiver or medical case manager what their role is right now. And then me as a therapist, I have my role and what that is at each of the levels. And then the ATP has their role at each level, because we all have to interact, or we all get to interact, which is great. But what I see like happening sometimes is the person kind of drops off at times and they don't really know what's happening because it's a lengthy process. And each of us gets confused over sometimes who's doing what. And sometimes things get lost in the shuffle. So we're trying to be more cognizant of those pieces and how they happen and what the role of each player is, so that we can keep interacting in this circle and keep the person informed. And then the big other thing at the end is oftentimes a therapist is involved all the way up until the device comes. And then when the device comes, oftentimes clinical therapists are already done with the person. And so it's the ATP that's going out to do the fitting and things like that. But there are times when the therapist can be involved in to the end. Like in my program, we always want to go out when the person gets their device. We always want to be there. And that's what we're trying to teach the vendors we're working with too, because sometimes they're not used to that. And sometimes we don't know that the product was delivered until it's already there. And so we're trying to make sure all those pieces happen and we have good communication about, for this person, how are we going to do this from start to end, so everybody understands those pieces. And what we've been finding is that last piece, when we go in at the end and make the adjustments and teach the person how to use it, are some of the most important pieces we do as therapists. And it helps the person be safe and to continue to use the device. So it's been really fun to see that.
Excellent. Thanks, Sue. One thing I want to, kind of stress upon is the individual that we're working with and what we call them, because I think everyone in this circle may call them something different. As I work with work comp more and more, not so much as case managers, but case managers then have to talk the lingo of work comp when they're speaking to adjusters and carriers. It's always an injured worker or IW, and that was sort of new to me back when that was thrown up, because when I started, everyone was a patient, and then we went to the person first, to where an individual with a disability. A lot of times we'll still call them clients or customers, but everyone will call them something different. But I think it's important to be respectful of that person that we're dealing with and understand their needs. So thank you, Sue.
Yep. There's a couple questions, Mike, so I don't know if you want them now or at the end.
I think, if I haven't been looking at the questions, but if you want to address a couple
there's
of
one for you.
Okay. How do you navigate the task of giving the patient all the options available when doing a seating eval in an inpatient rehab setting? I pose this question because when a client reaches the inpatient setting, typically they are still in the acute phase of their injury and most likely will not be able to process the plethora of products available. I'm a clinician that is planning to sit for my ATP certification in a month. And, interesting question, because, if the client's in an inpatient rehab setting, this should be probably easier to try various equipment. And, and especially, and a lot of the relationships with clients that I have gotten started in an inpatient setting with a therapist or that therapy team and a physician and a case manager that's, probably an external case manager, whether it's work comp or private insurance, and an internal case manager. And, and we start with what type of product, our assistive technology intervention, do we think this client's going to need? Is it going to be a power chair with multi-power seating options? Is it going to be an ultra lightweight chair? And then, we get product in, maybe 3, if it's a power chair, we may try 2 different brands of power chairs with options and let the client go back and forth and try those. If it's an ultralight chair, there may be 3 options that they try. And we try to get, you're always trying to get as close to the custom perfect fit chair as possible but that never works out well. But there are options available, and I you just have to make the best choices with the therapy team you have, and understanding that in ultra lightweight chairs, if you can try 3 and let the client and let that client individual decide which one they like the feel of best, and then we go from there. I think we've been very successful in that model. I think could it be improved on? Would it be wonderful if we had a lot more demo products or could get chairs custom fit to individuals? Absolutely. But unfortunately, that doesn't happen all the time. We're limited with resources and demo products to let clients trial, but you always want to let clients try a couple products. I'd be curious if there, I know there's some inpatient rehab therapists. I think I saw a couple names attending that have a lot of experience. If they have more insight into answering that question, and if I answered it appropriately or not.
I think the only other thing I would say too is because I did used to work inpatient and then rehab and now in-home, that there will be changes along the way. So we're trying to look at a chair that fits the person now, but then we know that there will be changes along the way. So trying the chair and then fitting the chair and getting the person something that if they improve, we know we can make changes to it, or if they need different controls later, we can change that. And then planning in if we're going to be needing environmental controls built in and all of that. So just starting to prep those pieces so that we know the chair can meet those needs later if needed. Because I oftentimes will, after someone's done with rehab and then they're in the home for a while and they're progressing, we change out the different types of controls that they're using. We add in the environmental controls. So just making sure that we know the chair can do that later. And then we continue to work as a team as the person progresses, or the other way too, that the chair can fit the person. And then if the person has a declining condition, we can add in things later too.
Yeah. You know, the seating components, there's always the ability to get a lot of different cushions and different back supports tend to maybe be easier to get more of than the actual wheelchair bases. And then the options and accessories are generally matched to the client's needs. And sometimes you might have to try some different headrests, you know, different arm supports, foot boxes or foot supports, different support pads, laterals. So those tend to be a little bit easier to narrow down, but that the base of the chair is what I think a lot of individuals struggle with, probably more so on a spinal cord injury side with an ultra lightweight, letting them choose some products and try them. I think we struggle with that a little bit more than other things, but anyway, we can carry this conversation, you know, on further too. But you know, looking at collaboration, one of boundaries, whose scope of practice is what, and we've kind of been talking about that, and understand responsibilities and limitations of each role. Setting boundaries and outlining the scope of practice is very important in the delivery of AT. Knowing who does what and what limitations there may be can eliminate issues. And I just can't stress this enough that this needs to be outlined up front initially with the client and sometimes even the case manager. If they're wanting something, I'm trying to struggle for a good example right now, but we've all had clients that want something that just is not appropriate. It's not going to work. And sometimes you just have to prove it to them, or we can't even, we can't get it. Or they want us to do something that is so outside, excuse me, our, what we should be doing. We have to say, no, we can't do that. Or we're not going to be able to do that. Here's the, we've, if someone has, Medicaid and they're calling, they want a chair in, before they're going on a trip this weekend, guess what? That is not going to happen. So don't set them up thinking they're going to get a chair that they own, before this weekend. We can maybe loan you something to use if you've got a trip, but it's not going to be your own chair and it may not be perfect for you. So we've all had weird situations like that. Making sure everyone understands the roles and responsibilities up front is key to a successful transition. Don't ignore difficult conversations about what the assistive technology will or will not do, what is covered and paid for versus what will have to be private pay. Be honest and straightforward. Work to find solutions with the team to issues that are brought up. Something that comes up a lot are power seat elevators. People are out in public and they talk to other people and they're like, wow, you got that power seat elevator. And they're like, yeah, my insurance covered it. Maybe they did, maybe they didn't. most people private pay for power seat elevators unless you're a work comp or have a policy that has them covered. So you have to, really know the situation. But, just because someone else got it covered or had it paid for doesn't mean you have that coverage benefit. And, here's what they cost to have. Sure, they're great to have. I'd love to get you one. Let's figure out how, but you're going to have to pay for it yourself. Don't, one of my favorite sayings for as long as I've been in ATP is don't overpromise and underdeliver. You've got to be so careful with that. Sue?
Yes, and I would agree with everything. And then just a quick couple add-ons to that is that being honest with the person also in how long the process takes, because again, not just getting a chair for a vacation, but getting a chair in general, people do think, or a scooter or durable medical equipment, that pretty much as soon as I need it, as soon as you assess for it, I'm going to get it. And so we have to be really honest with how long this process takes. And I always overestimate so the person knows that, and that we keep them informed. That's the other big piece, that all of these players have a role in keeping that person updated, and that helps a lot. So being honest with the time frame and updating the person. Little things also to tell the person in the very beginning and their team that can make a huge impact is that oftentimes for the items that need a physician order and a physician face-to-face, nobody knows what that means. Like the case manager might not know what that means. The person might not know what that means. The therapist does, and the ATP supplier does. But sometimes the physician also doesn't know what they're expected of to give you for that. And so being really clear about that, because I see that as a delay too, even though it's a simple delay, that the person doesn't understand that they need to get this. And this face-to-face right now sometimes can happen remotely, but not all physicians do it remotely. So that person does need to know where that needs to occur, and some planning has to occur around that. And oftentimes a support person to get the person to that appointment if they need it. We often get a lot of delays, either me or the ATP vendor sees this too, in that piece happening, smoothly, or the physician supplying what is needed. So I also see a huge role for case managers, ATP suppliers, and us therapists to educate the person and the physician on those pieces, and then to even give examples to the physician of what you're looking for and what's needed from them so that they can provide it in the right way. And then who's going to get that? Because sometimes vendors do it and sometimes the therapist does it.
Yes. And that can get confusing. In an inpatient rehab setting, if you have your team meetings, it's easily managed to get what the documentation you need and get it signed by the physician at team meetings, unless you have a physician that just is refusing to sign anything except at his office, which, as we all won't get into the nuances of working with the personalities of different physicians, but that's always interesting. So, all right. All right, come on, computer, work for me here. Here we go. Communication from the case manager. We should have expectations for the case manager to be honest and upfront with us as well. We need all the information about the clients to meet their needs effectively. Are there psychological issues, behavioral issues, family issues, anything that can make it difficult to meet the ATP needs of the client? I have so many different examples of situations I've walked into that no one warned me about, where spinal cord injury patients whose family drives up from the other side of the state, beats him up and steals all his money, and steals the wheelchair. It's just, you can't make some of this stuff up that happens. Or the ex-wife is the caregiver, but they hate each other and they throw stuff at each other, and you're dodging a pan and a plate while you're there trying to do a wheelchair valve. This stuff happens. So we have to have that comprehensive information exchange to the team. I've said this to case managers before: give me the lowdown on the client, the good, the bad, the ugly. What is going on? If you're going to send me into a home, or I'm sure therapists even on inpatient stays have walked into the room and gotten in the middle of something going on with a family or a significant other, or whatever. You don't want to get in the middle of that, or you want to be aware of it and try to control it and help facilitate the issues. The case manager should be expected to give us the current history and physical. What are the medical diagnoses? All of them. Updated info on the medical and therapy treatment goals and expectations. What are the client's expectations here? Are they realistic? Do they match the case manager's expectations? The case manager may be telling you something, the client may be telling you something else, and they haven't had a conversation. And you've been sent in to, hey, guess what? Why don't you break the news that we're not covering this? We're just going to get them a standard wheelchair instead of the ultra lightweight chair, because the adjuster doesn't want to pay any more than this for a chair. Well, that's not going to work. So, we all need to get together on this. And what are the expected outcomes? And then, of course, as a supplier, and, payment of equipment, and then the medical necessity, who, what, where, how, why, what do we need to do for it? As you talked earlier about expectations and timeframes, a work comp order can be processed very, very quickly. I've had case managers say, hey, I need you to go see, it's a replacement wheelchair. This guy's been in a wheelchair for 20 years. He wants a new one. Can you go see him? And we may go out, do an evaluation, meet with him, go through everything. I send a quote, that day to the case manager, and she's like, send it back, signed off, approved. We can order the chair that day. The guy gets the chair as soon as we can have it made. If it's another insurance, we may have to wait to go in for a clinic appointment for a wheelchair clinic. We need to get documentation. I usually don't have to, well, yeah, you have to get documentation if it's private insurance, Medicare or Medicaid, you're going to have to submit it for a PA. You could be looking at a month, 6 weeks, hopefully, if everything goes smoothly. So, Sue?
Yeah, I agree with all of those things. And then just the ATP and the therapist and the person and the team communicating,
Yeah.
and the
Yeah.
honesty and knowing everything as much as you can is super helpful, because we're going in the home too. And so I do always talk to the case manager, because I don't want to get I literally had a case manager once send me a box of files on a person, and I don't want that either. Getting the right information.
Yeah.
Yeah.
All right. Well, we got about 10 minutes, Sue, or 8 minutes. So let's see if we. External considerations with the team. How can the ATP supplier facilitate? Ensuring all team members, especially the individual we are serving, understand the requirements for coverage and how they can assist in the process can be very beneficial to order flow. Timeline expectations between private insurance, Medicare, Medicaid, order processing versus expectations from the work comp arena are very different. When we have the ability to move orders quickly, we should do just that. If the work comp case manager only requires a quote, send it ASAP. I've seen approval happen in a day in many situations. I've also seen ATPs not create a quote until their office day, and then the order processing person in their office hold it until they get to it. And all these delays cause frustration and poor customer service. These are the same delays that add days to other order processing timelines as well. It is crucial for an ATP supplier to manage orders and ensure they are moving. So
Perfect.
I think that's
everything.
Yeah, it really is. I think ATPs have the ability to manage internally their orders and make sure they're moving, and don't let them get stuck in a pending status, or the doctor's not signing. If the doctor's not doing something or the therapist's not doing something, we need to be able to call it, we need to be able to call the client and explain that to them. And here's what we need you to do to help us move this through the system quickly. With Medicare, we all know we have to have a face-to-face. And we have clients that don't want to go do that. Well, you're not going to get equipment until you do the face-to-face. So, all right, let's, Internal considerations, how can ATPs be case managers within their business? And, again, a supplier ATP can manage the order process by understanding what is required and not just for payment. Have expectations been set with the client and case manager, therapy team, and your internal order processing team at the CRT company? Do you turn the order over to staff and move on, or do you actively manage your orders to ensure they are moving through the order processing system without unnecessary delays? Directing your internal team and setting expectations of timelines and customer service updates on the order, ATP evaluations and quotes turned in quickly, delivery and setup. I think, this is something that the ATP can drive, is especially the customer service expectations. How do you want your customers? How do we treat our customers? How do we talk to our customers? How do we treat case managers, therapists, physicians, everyone in that circle? It's set by you, the ATP, as the example, and staff should follow your example of how you treat people. What documentation is needed and timely collection of documentation for submission of that PA. Work comp requirements versus Medicare. Medicaid and private insurance requirements are different and can be managed differently. Standards, the RESNA standard of practice number 12 says provide adjustments, instructions, and any modifications to minimize risk. This is the #1 consumer complaint, especially when there is an actual or perceived lack of communication and responsiveness to address the problems they're having with their assistive technology. To minimize this issue and the he said, she said dispute associated with it, document all your conversations and any adjustments, modifications, and instructions for use you provide, and the next steps that were agreed upon. This is important for both the client and the next person who works with the client, even if it is you, because your memory is never as good as you think it is.
Perfect.
Sue, anything you want to add to that? I think
nope, that's perfect.
Yeah, I think supplier ATPs probably do not document as well as they should, and it would help solve a lot of issues. What can happen without communication and collaboration? I think we all know that. We've kind of been talking about some of the issues, when boundaries, expectations, and limitations are not set, setting yourself up for failure, and are finding yourself overextended and in situations trying to meet needs and demands that are very difficult or impossible. Funding becomes a concern in these situations quickly as you overpromise what cannot be approved or covered. Don't overlook any stakeholders either. Caregivers, parents, teachers, all are important when determining assistive technology needs and whether it will or can be utilized efficiently or not. When everyone is on the same page about what can and cannot be achieved, you'll have better outcomes.
Yeah, perfect.
Establishing outcomes within the team is crucial to ensure they are obstacles and can be funded, or how they will be funded. Private insurance versus work comp coverage and goals, again, can generally are very different. Listening to the client and understanding their needs, wants, and listening to the case manager to understand coverage must occur. Always remember our customers, clients, and patients are individuals with specific goals and AT needs. Approaching the interaction as human being to human being will always win over a perceived customer and wheelchair salesman type relationship. Test assumptions so there is no guessing in the process. Don't be afraid to get a second opinion in difficult situations, whether another ATP or clinician, family member, or caregiver. When you do all of this, you build trust and will achieve goals successfully.
Perfect.
Again, goals are achieved teamwork through collaboration and communication, and most importantly, ATPs acting as an internal case manager at their employer, supplier, and managing that transaction much as the case manager that's referred to them expects them to do. I've got many 30-year plus relationships with case managers, and I know each one of them's expectation of us and what they want. And it's taken a lot of years to get there, but you can get there too. You just have to, you be accountable, ownership, and provide quality service, and care about the clients you serve and take care of them.
Mhm.
So do we have some time? Are there any more questions that we missed out on here?
I don't see any more in the chat, but we're open to questions.
Yep.
Either unmute and ask or put them in the chat.
Before we answer questions, I'll just throw out the CEU code. It is 8DIBWY, and that is in the chat.
Thanks.
Excellent. Well, we're happy to answer questions. Hopefully we answered the question about the inpatient rehab and the array of material or equipment for folks to try.
Mhm.
That is, the easiest place to do that is an inpatient rehab setting. When you have a client that's at home or not in rehab, that makes it so much more difficult to do
Mhm.
trying that equipment.
Yeah, we do it, but it is like stages, and you can't do it all at once, so it takes
Right.
a lot longer. Yep.
All right, if there are no more questions, thank you all for joining. Again, that code is 8DIBWY, and we'll see you in the following sessions.
Thanks, you guys.
Thank you all.